Hello everyone, thanks for listening to this presentation. My name is Charlotte Garlotte and I work at Coxida in Montreal. I will present the result of our community-based research about access to care and treatment for people living with HIV with a precarious immigration status and sometimes with a temporary immigration status. And here we're going to focus on the barriers. This project was led by Ken Montis from Coxida and Christina Zarowski from University of Montreal, and a big team, an amazing team that you can see all of the name below. A French version of this presentation will be on our website. You can see the link here at coxida.com. This project was funded by CRHR. I have no conflict of interest to declare. In our project, we define an immigrant as a person born outside of the country who now reside in Canada. An immigrant will have a lot of different immigration status, and the problem we are facing here is because all of them have a different admissibility to a healthcare insurance. Canadian citizens, if he or she was born in Canada to parents with precarious status, he has the same health insurance than his parents, sometimes none. Temporary resident immigrants have different kind of access, and this category is really complicated to understand. It could be difficult also for asylum seekers to have health insurance, even if there is one. And there is nothing for people without any status. We know that in 2017, 30% of the newly diagnosed of HIV to HIV were not covered by the Quebec Health Insurance Plan and also were immigrant. But we don't know the actual number of people living with HIV who do not have access to care and treatment because of their immigration status. And we don't know the impact of their health to be in this situation. So we raise the question, why in Quebec today we not have yet a system to guarantee access to care and treatment for all of the people living with HIV? This raised ethical reflections, especially with this new pandemic right now. Our objective was to document the states of access to healthcare from the point of view of the professional, community-based clinic, etc. We didn't interview here people living with HIV in this project. We wanted also to identify short-term solution and also we wanted to explore strategy to establish universal health coverage in Quebec for people living with HIV and to develop a more complete research project. Our methodology, we were looking for a diversity of point of views, and we have done 22 qualitative interviews with the people from different kind of affiliation. You can see all of them on the right. We have done also 2 focus group, 3 participant observation. We use QDR Miner for our qualitative analysis, and we interpret the data with all of the members of our team and with 17 persons living with HIV with immigration background. The result. The good news is there is some alternative way to give HIV treatment and care, even without an health insurance. So there is several clinics that offer screening and consultation free of charge and without an insurance card. C'est des plus Médecins du Monde, Clinique Sida Amitié, Gavé Mobile Clinic, for example. But the problem comes with the lab test. So our results show that some tests could be done free of charge for the person because of some collaboration between institutions. So the collaboration here helped a lot. Same problem for having access to the treatment. Here we noticed that doctors, pharmacists, and individuals found some ways to get the treatment. Sometimes even use a creative way. And sometimes for the individual, they use illegal way too because they really need to get access to the treatment. So there is no other option. In our presentation, we want to focus on the barriers that block the access to care. We noticed that there is a lot of barriers directly linked with the immigration status as we first knew. So here barriers are political, administrative, and financial. So for example, low involvement of decision makers are not helping to open up RMQ admissibility that today not accept people with a precarious immigration status. And services and treatment are really expensive. And we know, for example, that a student or an asylum seeker have often low income. What we find interested is there is some barriers not linked to immigration status, such as a lack of information for social worker and health professional. We often know this person don't know sometimes about the difference of immigration statuses and their rights. Some also don't know about the federal program for the asylum seeker. For people, we find that there is a lack of knowledge about the existing HIV services. They don't know where to go. And there is a still false belief about the risk of HIV transmission. Information often comes with communication. We find also that there is a lack of internal communication between organizations from the same network. So inside between community-based organizations, between clinics, etc. There is also a lack of communication between services, so between clinic and community-based organization, and some resistance sometimes to collaborate between each others. Yes, there is a lot of collaborations going on right now, but we can do better. There is also cultural, linguistic, and geographic barriers, and unfortunately, there is still stigma. So information, communication, and collaboration are linked together, and in all levels, we could do something about it to improve it. To conclude, yes, there is services that support and provide care for people living with HIV without any or limited healthcare insurance. There is good result when department and organization are working together, but all of these are limited solution because there are limited human and financial resources. Doctors are often working on a voluntary basis. Certain services exist thanks to the goodwill of certain professionals, and there is still a lack of communication, collaboration, and information. The solution where we are going to work now is to consolidate our collaboration and combine all of these services in a broad continuum with close collaboration, because this is the key. We also develop a new research project where we are going to work with this continuum of services. This continuum of services is called Cercle Orange. It's a pilot project hosted now at Coxida and initiated by SSKP1.02. You can see the poster on this online conference now. We are also going to promote our research result, offer some training, and apply to a grant for a new research project. Our new research project will try to go toward long-term solutions. We are planning to develop advocacy, so maybe we can do some change here. So we are going to document the number of people in this situation to demonstrate to the public health institution that the problem exists. And we want to demonstrate also to them their responsibility for the health of all of the people living in Quebec, especially for people living with HIV. And also we want to demonstrate that public health benefits of providing universal coverage. This is actually a really good thing to do, even about money. So we want to demand to extend our public health coverage to all people living with HIV without consideration for immigration status. We want to move towards the implementation of universal health coverage in Quebec and maybe in all Canada. If you have any comments or questions, please email us. And once again, the French version of this presentation is going to be online. Thank you very much.